Dr. Chad Myers. For those of you who don't know Dr. Myers, he is the director of the Division of Emergency Critical Care for the Mount Sinai system, as well as the director of emergency critical care at Elmhurst Hospital Center. He completed his residency in emergency medicine at Mount Sinai and did fellowship in anesthesia crit care at the Brigham Hospital in Boston, one of those mass gen hospitals. He currently practices clinically in both the emergency department and in the surgical trauma ICU at Elmhurst. And today he's going to talk to us about fluid tolerance and how to measure and how to kind of figure out fluid responsiveness for patients, which is a topic I've been asking him to give us for a while because I'm very interested in it. So thank you so much, Dr. Myers, for coming, and I will let you get started.
All right, thank you, Evan. All right, so I'm gonna go ahead and share my screen here. Let's see, can you see that?
Yes.
Yep, we can see it.
All right, perfect. So thank you for the introduction. To give you a little background, this is sort of a topic that's been a focus of mine for a long time. I think the first time I gave a version of this lecture was right after fellowship in 2008. And over these last, 15 years, I've sort of retooled this, continually adjusted it for evidence. And obviously, both practice and evidence have changed pretty substantially, and so does this lecture. Now, a disclaimer, there's some of the components of this, there's obviously a lack of evidence. So, these are my opinions, and this is my interpretation of sort of best evidence. So there are going to be, I'm sure, some components of this that are considered maybe a little controversial, especially in those recommendations made outside of fantastic evidence. So I look forward to discussion either after the lecture or via email. Additionally, there's a lot to cover, so I'm going to move through a lot of the topics very quickly. At the end, I'm going to give you all a link that'll take you to all of my references, PubMed links, and whatnot. All right, no disclosures. All right, so I always start this lecture with a case. I think probably the most representative case would be a patient who's either newly arrived to the ICU, either postoperatively or coming from the emergency room, or maybe even a patient who's still in the emergency room who suspects septic shock or is already being treated for septic shock. I think the more complex patient would be an elderly patient who perhaps has a lot of comorbidities, maybe already has a degree AKI without much baseline known, has cardiac risk factors, but hasn't had any formal cardiac evaluation at this point in their care. So in that way, it's sort of a blank slate. And I think most people would approach this patient with the first question would be, pressors or fluids, right? So, in terms of our strategies or broad strategies for fluid and septic shock, I'll sort of break them down into four main categories. Our first two being relatively blind, if not blind, starting with a fluid bolus and then either giving fluids until the patient is clinically overloaded and then starting pressors, or a restrictive strategy where you give a bolus and then early vasopressors. And then we have our protocolized approaches like early goal-directed therapy. Over the years, for the most part, obviously, evidence has really failed to demonstrate any benefit of one of these over the other. So at this point, for the rest of this lecture, we're going to be focusing on guided therapies, specifically looking at therapies centered around the concepts of fluid responsiveness and fluid tolerance. Now, some basic definitions to make sure that we're all on the same page. What is fluid responsiveness? I think we are all familiar with this, but just in case, this is the concept. If we give fluid, do we see a corresponding increase in cardiac output? And this is what's demonstrated by the Frank-Starling curve, where we see an increase in ventricular end diastolic volume, and we see a corresponding increase in stroke volume. This represents a patient who's fluid responsive. Now, fluid responsiveness arguably has been considered the holy grail of fluid administration in the ICU for probably the better part of the last 20 years, if not more. The question is there really any evidence to suggest that this actually improves clinical outcomes? Many of you are probably familiar with this meta-analysis from 2017, looking at 13 trials in the ICU and evaluating for the effect of fluid responsiveness, which found basically an associated decreased mortality as well as ICU length of stay. However, only one of these trials included septic patients. A quarter of them were only in the operating room, and most of these were high-risk intra-abdominal surgical patients. So the question of whether or not this is broadly applicable, especially when we're talking about the patient that we're considering here, a septic patient, is sorry, it's definitely questionable. Now, two more recent meta-analysis, and there are a lot of crossover between these two analyses, looking at broadly strategies guided by fluid responsiveness versus those specifically guided by passive leg raise, found that there was no associated benefit in terms of mortality when compared to standard of care. Now, these aren't huge, great data, and these aren't huge studies, but it is food for thought. Now, you can come up with some limitations of fluid responsiveness when maybe explains the lack of benefit. Partly, very little of the crystalloid that we even give to healthy patients remains in circulation. And it's been measured even less, around 5% estimated crystalloid remains in the circulation an hour after administration. And this is also what was demonstrated by Nunez back in 2014. We had 20 patients, most of whom were septic, with PAC catheters in place. He looked at cardiac index over time after giving a patient of these patients volume boluses, and found that a majority of the benefit of that crystalloid was actually lost by about an hour and a half. So one of the limitations of fluid responsiveness is that it's a strategy that's driven mostly, if not only, by sort of a focus on the benefit of fluid. You can imagine, given the short-lived efficacy of fluid in sepsis, if we're continually chasing this fleeting increase in cardiac output, it's not hard to imagine that eventually we're going to reach supraphysiologic pressures. And that's exactly what was found by Ricard. This is one of the studies that was included in those meta-analysis. He had 60 septic patients who had PICO monitors in place, and he compared fluid strategies either guided by central venous pressure or by, in the experimental arm, looking at cardiac output and judging fluid responsiveness by passive leg raise. And I found that basically both arms had sustained elevated central venous pressures, and by day 6, pretty substantially elevated CVPs. Now, the definition of fluid tolerance is more difficult because there's no real consensus on what fluid tolerance is. But I think most can agree that fluid tolerance, although sometimes used interchangeably with the concept of fluid responsiveness, they're not the same. And part of this is that it recognizes a benefit of fluid, but it also acknowledges that there's also potential harm. Now, in my opinion, this concept is demonstrated probably best by the work of Arthur Guyton back in the 60s, where he took in account the importance of the RV as well as venous return. Now, I'm not going to spend much of my time talking about Guyton physiology. So for anybody who's unfamiliar, I recommend going back to some of the reviews by Sheldon Magder. He has a handful of reviews, put this in a clinical context, definitely well worth your time in terms of giving you understanding about sort of these concepts. Now, briefly, looking at the Guyton curves here, where he plots cardiac function curve against venous function curve, this intersection is what he referred to as the working right atrial pressure, as well as cardiac output. Now, in the state of severe unstressed or stress volume loss, where we see a decreased mean systemic filling pressure, we see a new intersection here that's out in the plateau of the venous function curve, where right atrial pressure is potentially lower than intrathoracic pressure, and we see basically venous collapse. And this results in what's been referred to as the so-called waterfall effect, where you see basically a thin-walled vascular venous structure is sort of fluttering open and closed. And we see not necessarily a termination or a stop of flow, we see a limitation of flow. This results in a decoupling of venous return and cardiac output. So if we see an increase in contractility, either intrinsically by sympathetic surge or extrinsically by the administration of inotropy or vasopressors, our cardiac output remains unchanged. Now, obviously, intervention is simple here. Give the patient volume, or we decrease vascular capacitance. Our goal is to just get the patient back out of this sort of return limited phase of venous function, and where cardiac output can be increased as a response to either positive inotropy intrinsically or extrinsically. So in my opinion, this is the critical goal of fluid resuscitation, right? Is avoiding flow limitation by inadequate venous return, as opposed to maxing out preload to potentially extreme values. Now, in terms of the acknowledgement of harm of fluid, what happens when we keep on giving fluids to our patients and push them out into the plateau where our flow is limited by cardiac function? Now, Guyton didn't necessarily describe what occurs in the setting of volume overload, and for that matter, neither did Starling, neither did Otto Frank. But what he did describe is that the heart's preload limits operate at the threshold of the RV and not the LV. So while the LV can tolerate extraordinarily high preload states, the RV can't. So what are the limits of the right heart, and what are the consequences of exceeding those limits? We go back to the post hoc analysis of the VAST trial back in 2011, where they looked at vasopressin and norepi and septic shock. What they found was that CVPs of over 8, and most substantially CVPs over 12, were associated with an increased mortality. And a couple of subsequent retrospective reviews or studies, first in 2013, looking at septic patients in the ICU, they found that CVPs of greater than 12 were associated with increased risk of AKI. And a larger retrospective study, 2017, looking at 500,000 patient records in the MIMIC database out of Beth Israel, found that CVPs of greater than 10 were associated with increased 28-day mortality in a variety of pathology. And then most recently, in a meta-analysis from 2020, looking at 15 studies, found that basically both mortality and AKI were associated with elevated CVPs in critically ill patients. And this was both on dichotomous scales. Here they looked at both 8, 10, and 12, as well as continuous scales. So to me, when we're talking about fluid tolerance, we're talking about a strategy that avoids, that's basically targeting or avoiding sort of extremes, right? We're going to give fluid in order to restore circulation, but limiting it to CVPs, below CVPs that we found that potentially could be dangerous. Now, a lot of you are probably saying, didn't we already go through all this with CVP 20 years ago with early goal-directed therapy? My argument would be that we were probably using CVP incorrectly at the time. Instead of using it as a goal, we probably should have been using it as a limit. And in fact, I'll admit that honestly, I was not aware of this in my initial understanding of the design for early goal-directed therapy. But in both the control as well as the experimental arm in early goal-directed therapy, both targeted CVPs of 8 to 12. And in fact, when looking at CVPs at 6 and 72 hours, both basically had supraphysiologic as well as potentially harmful values. There's been a lot of talk about the sort of above average mortality in the control arm of early goal-directed therapy, usually attributed to sort of the comorbidities that were present in the test population. However, this is a provocative question, but what if the mortality was actually related inadvertently to the actual study protocol itself? And before you assume that I'm saying just run all your patients totally dry, there's probably a sweet spot here, right? So if we go back to the VAST trial, where they did find an association with improved survival and 12-hour fluid balance with a lower 12-hour fluid balance, that relationship was actually reversed in that subcategory of patients that had lower CVPs, meaning that patients who got lower volumes, had lower filling pressures, these patients did more poorly. Obviously not great data, but again, my gut is that there's obviously limits in terms of how dry these patients can be. So now you're asking, obviously we have a sort of a limit in terms of our therapy. What do we use as our goal in terms of administering fluid? And this is where things get more complicated. And I think part of the problem of most of the study designs that we've gone through is that our patients in the ICU are just too clinically complex to adequately protocolize. So what I say is you start with a patient who's in shock, and by whatever criteria, right? Are they oliguric or anuric, or just have renal dysfunction? Are they hypotensive, hypoxemic? Are they altered? Or maybe they have some sort of global indicator of malperfusion. If the patient, it makes sense clinically, the patient needs volume, then we do an evaluation and determine whether or not the patient's fluid tolerant. If they do, then we consider a fluid challenge. And then we loop back around and see whether or not that patient clinically improved. This is obviously a lot more difficult to put into a protocol, but I think it sort of requires, for lack of better words, some clinical artistry. So now to the fun part of the lecture. How do we actually determine fluid tolerance? Now, over the years, you know, I've come up with some pretty complex approaches to volume assessment that I've tried to convince people essentially to incorporate in their clinical sort of care. But in a busy ED or ICU, asking clinicians to perform lengthy studies to answer a simple question like, can I give fluid to this patient, especially in patients who aren't objectively even sick yet, I'll admit is a pretty tough ask. And in my own practice, trying to incorporate for every one of these patients some an evaluation that takes valuable time, yeah, it's a tall order. So my requirements for what I would call a practical strategy incorporates a handful of things. The first is it should be fast, and part of that is to allow it to be applied early and then potentially repeatedly, right? And the same patient or in the same ICU. It needs to be reproducible, right? Not just by me and other operators, but also in intubated and spontaneously breathing patients. It ideally should be non-invasive or at least minimally invasive. And it should require no specialized equipment aside from a bedside ultrasound. So no Nikon monitors or Cheetahs or Vigileas that most people are not going to have available. And it should be multimodal. And by this, I mean, I'm incorporating 2D ultrasound, Doppler. I'm going to look at multiple organ systems so that there's no real over-reliance on just one single measure. Now, breaking down our targets in terms of assessment, if you think about our sort of indicators of fluid responsiveness, we think about the left ventricle. Fluid tolerance, on the other hand, we're thinking about the right ventricle. Now, these by no means is supposed to be a complete list of ways to evaluate for fluid responsiveness, but in general, most indicators of fluid responsiveness don't meet my sort of minimum requirement of practicality, right? They're either invasive or they require a patient to be not triggering the ventilator, or they require some specialized equipment. Now, with the exception of perhaps echo measurements of LVOT, VTI, and we'll talk a little bit of how I incorporate that into my care. Now, the right side is a lot easier to evaluate, and we have a lot more at our disposal because evaluating right atrial pressure is a little bit simpler. And we can start with evaluation of inferior vena cava, looking at both collapse as well as static diameter. We're going to talk a little bit about how I incorporate solid organ Doppler in terms of my assessment. And then we'll also talk about sort of the limitations and also the role of echo as well as lung ultrasound. All right, so starting with respiratory variation of the vena cava. Now, much like CVP, I think this is obviously is often misunderstood. And I think part of that understanding comes from the fact that for the longest time, people have been trying to assign the capability of identifying fluid responsiveness with respiratory variation of the vena cava. And it's just not capable of doing that, unsurprisingly. However, when we're looking at filling pressures, right-sided filling pressures specifically, this is where the vena cava becomes and performs a lot better. Now, I think everybody's familiar with how to perform an IVC assessment. Just because of the importance of it with the evaluation, I just want to go over this very briefly. So I start with a subxiphoid view. I start with a longitudinal assessment of the IVC, and I'm going to look primarily at the segment that's just at least a few centimeters proximal to the hepatic veins. NAGDEV 2010, this is an emergency department study, found that basically greater than 50% collapse of the IVC was associated with a CVP of less than 8. And this is in both spontaneously breathing and also mechanically ventilated patients. Kircher, in a study that actually was earlier in ICU patients with right heart cath, found that with decreasing collapse, there was greater predictive value in terms of identifying CVPs that were greater than 10, with 50% again being sort of the strongest indicators. Now, the ASC recommendations for right heart evaluation from 2010 also incorporate the measurement of static measurements of the IVC. Now, how I incorporate this into my care in terms of simplification is I emphasize collapse first. If I see greater than 50% collapse, then I basically identify these patients of having low or at least normal CVPs. On the other hand, sorry, let's go back. If the patient has less than 50% collapse, this is when I take a measurement. And especially this is the case in a patient who's potentially not able to cooperate with your exams, unable to take deep inspiration, take a measurement. If the CVP or the IVC, I'm sorry, is less than 2.1 centimeters, then I classify these patients as low. If it is greater than 2 centimeters, these patients have this identifies right atrial pressures that are greater than 15, or at least greater than 10. All right, and this is a patient who has a larger respiratory IVC, and if we were to measure this, I'm sure it'd be over 2. Now, there's some important confounders here. Both any obstructive cause of shock, either tamponade or pneumothorax, obviously, and then signs of venous congestion in general are not going to be able to differentiate pressure from volume overload of the RV. Any pathology that raises intra-abdominal pressure is going to cause some problems here. And then well-trained athletes, specifically swimmers, can have dilated IVCs despite having normal right atrial pressures. This has something to do with sort of adaptation with significant exercise. And then finally, probably most importantly, it's our probe position. Specifically looking what is known as pseudocollapse. And so we're looking longitudinally at its tubular structure. If you just move if your probe just moves off to the side, obviously you're going to see a significant chance of collapse, and you're going to falsely identify lower pressures. So if there's any question about probe position, then we just turn the probe and also measure it in transverse. I wish I didn't have to actually even mention this, but I think it is important to talk about the utility of IVC in mechanically ventilated patients, and this pertains to both invasive and non-invasively ventilated patients. I will say, without a doubt, this is probably one of the more disappointing absences of good evidence, given the fact that we've been using ultrasound assessment for so long. You would think that we'd have better evidence. And just as an example, this is a review of 21 studies. Only 8 of these included ventilated patients, and only 5 of those are outside of the operating room. The problem with these studies is very few actually specified vent settings, and none actually specified whether or not patients were breathing spontaneously or not. Now, it's commonly taught that positive pressure reverses the relationship between IVC and inspiration, right? That we get cable distension instead of collapse with positive pressure breaths. However, that's not exactly true, and it totally depends on whether or not the patient is breathing spontaneously or not. If the patient is able to generate negative intrathoracic pressures, you're still going to see collapse with inspiration. And this is demonstrated by Yu's study from 1992. He looked at 49 mechanically ventilated patients where he did not control for spontaneous breathing. And you can see the distribution of distension and collapse of the IVC was fairly well distributed. So how do I incorporate this in my care? And this is, again, these are my recommendations. And this acknowledges a couple of things, right? Evidence is terrible. And 2, that the actual ASE formally recommends against estimating CVP in mechanical ventilation. My own opinion is that's a little heavy-handed. So my incorporation is this. If I have a patient who's on non-invasive or pressure-supported ventilation on a mechanical ventilator, I don't change my parameters in terms of IVC evaluation. If they're on assist control, especially if they're overbreathing and they still have maintenance of this collapse greater than 50%, again, I assume that patient's got lower CVPs. If the patient's on assist control and I'm seeing minimal collapse or distension, this is where I think that you're left with some decisions. And the best evidence goes back to that Yu study, where he found that an expiratory IVC of less than 1.2 centimeters was associated with a CVP of less than 10. One caveat here is he measured expiratory IVC, which in most ventilated patients is going to be your minimum diameter across the respiratory cycle. And this is the opposite of what we're normally looking at in terms of spontaneous breathing. We're usually looking at our IVC max. And to put this in context, our spontaneously breathing IVC minimum is usually about 1.5 centimeters. So off by about 20%, not that terrible. All right, so moving on in terms of venous congestion, and specifically the use of solid organ Doppler to evaluate the vascular beds of both the kidneys and the liver. Now, if you look across these vascular beds, you're going to see some characteristic flow patterns, each of them a little different. I'm going to start with arguably the easiest of us to obtain, and that's looking at portal vein pulsatility. All right, so starting with probe position, simple. Start on the sort of mid-axillary line on the right side here. It's usually at the costal margin. My experience usually above, maybe between the first or second intercostal space there from the bottom. For that matter, I tend to use my phased array probe here. Most people advocate using the abdominal probe. I have no problem in terms of getting signal with my cardiac probe. And you're going to identify the portal vein pretty easily by the sort of characteristic hyperechoic wall. Now, in the setting of normal right atrial pressures, we typically see very little conductance of pressure waveforms in the portal system. So in the setting of normal pressure, what that'll show is basically just a continuous sort of flow pattern without any real pulsatility, other than maybe some pulsatility generated just by movement artifact. Now, as pressure goes up, we see basically our right atrial pressure compliance go down, right? And that pressure waveforms are more readily transmitted through the hepatic sinusoids and all the way into the portal system. And then we see some portal pulsatility. With critical elevations of pulsatility, we actually see complete reversal of portal flow. Now moving on to some of my patients. So we can see here our portal vein. We can see our IVC in the back. We can see some actual pericholecystic fluid. I think this patient had cholangitis, if I remember correctly. And we put collar Doppler on here, and we can see that we have our characteristic flow that should be towards our probe. We put our pulse wave Doppler on. We see significant pulsatility here, greater than 50%. There's another patient, again, color Doppler. And then with pulse wave Doppler, we see continuous flow, indicating that the patient probably has normal right atrial pressures. And one more example here, color Doppler, we can already see that there's probably going to be pulsatile flow here. And that is indeed the case when we put our pulse wave Doppler in place and measure. Andre Deneau and his group out of Montreal has been looking at this for years in cardiac surgical patients. It started with a retrospective cohort study, and 102 patients found that portal pulsatility of greater than 50% was associated with increased risk of AKI, increased days in the vent, increased days duration of vasopressors, and increased ICU in hospital length of stay. Followed up with an observational study, 145 patients again post-CABG, and they found again portal pulsatility over 50% associated with AKI and severe AKI. There are some important confounders here. Cirrhotic patients can have pulsatility despite having normal right atrial pressures, and patients who are thin, BMIs of less than 20, you see sort of correlation as your BMI goes down, the incidence of portal pulsatility in the setting of normal right atrial pressures goes up. 1 second, just need to take one moment here. All right. All right, so moving on to hepatic Doppler. Adding maybe a little bit of complexity in terms of the ability to do this. Now, you can actually measure hepatic Doppler or hepatic flow in a number of positions, including subxiphoid. I think that you actually get a little bit less noise in our right lateral, almost the same position as portal vein. Sometimes you can actually get the hepatic vein and portal vein in your same window. And we'll see this characteristic flow pattern. It may look familiar to some of you in the sense that it's actually almost identical to the CVP. So it's going to have 3 main components, our atrial wave, and then a systolic and diastolic wave. And as our right atrial pressure goes up, the relationship between our systolic and diastolic wave is going to change. Our systolic wave is gradually going to sort of diminish and then reverse in severe right atrial pressure elevation. So some examples here. This is a normal relationship between your S and D wave. And here's where we see actually a reversal of our S wave. It's a patient of mine. Start with a view of the hepatic vein. You can see it sort of as it connects with the IVC. Put our pulse wave Doppler on, and we see this normal relationship between our S and D waves. Just sort of for confirmation, you can see the portal vein was actually in the same window here, and we see mostly continuous flow. And again, a little bit of sort of movement artifact is pretty common, but also a small amount of variability is also sort of is considered normal. Now moving on, probably order of magnitude of difficulty in terms of obtaining good images is renal Doppler. And it's difficult enough that in most spontaneously breathing patients, I don't even attempt to do this. unless they're fully capable of trying to hold their breath. So to keep the patient, it's pretty much off the table. If you are going to measure it, you first do color flow of the kidney, and you look for an intralobar vessel with good flow. And we basically measure with pulse wave Doppler. And the vessels are small enough and they run anti-parallel. So that in many cases, you'll actually see flow, both arterial flow and venous flow in the same window. Now, looking first at venous flow, you can see it's sort of a mix between the portal sort of patterns and our hepatic patterns. Low pressure, you see continuous flow, and then it changes into a biphasic pattern, and then finally a monophasic pattern. Arterial flow, we're going to look at the relationship of systolic velocity and end-diastolic velocity. And as our right atrial pressure goes up and renal congestion goes up, we're going to see a gradual decrease in terms of our diastolic velocities. If you calculate this, you get a renal resistive index, and if it's greater than 7 or greater than or equal to 8, this is considered elevated. All right, putting this all together, the same group out of Montreal with Deneau, now with Felipe Rolla, put all this together and created a grading system called the venous excess ultrasound, or otherwise known as the Vexa system. Starts with identifying patients with an IVC of greater than 2. Now, they did not include collapse in their evaluation, but apparently that was actually just a limitation of the study, not necessarily due to any sort of opinions otherwise about the value of collapse over static measurements. And then they looked at the presence of normal, mild, or severe Doppler flow patterns across each of these vascular beds we just talked about. So in hepatic vein Doppler, severe was considered S-wave reversal. Portal vein Doppler was pulsatility over 50%. And in intrarenal venous Doppler, it was monophasic flow patterns. They actually did not include renal resistive index in this evaluation. And what they found was, starting with an IVC that's dilated, you added any 2 severe Doppler abnormalities, this predicted the incidence of acute kidney injury. And when compared to CVPs, this is looking at comparing pre and post test probability of AKI, it outperformed CVP, albeit with a pretty poor sensitivity in terms of sensitivity of 27%. Now, in terms of incorporating echo, I start, and I think there's a lot of value in terms of sort of just an overall evaluation of left ventricular systolic function. And obviously, this doesn't necessarily correlate with venous congestion directly, but I do think having an overall idea of the health of the left ventricle is going to give me a lot of confidence in terms of how aggressive I want to be with volume, right? So even if I have a normal right atrial pressure, if I've got a hyperdynamic LV, then I may start with a larger fluid bolus than, say, somebody who's got a hypokinetic EF less than 30%, that even if their right atrial pressures I'm estimating as being low, I'm probably going to be pretty cautious with fluid out of fear that I may unmask LV failure. I'm also going to obviously look at sort of the diameter of my RV, looking for increased diameter there compared to my LV. And then probably most usefully, I'm going to be looking at my short axis and to look at the septum for any evidence of ventricular interdependence. Now, we talked about how the limitations of venous congestion is that it's unable to differentiate pressure from volume. However, the differential timing in terms of geometric distortion of septum can maybe give us some clues. All right, so both the middle video and the left, these are in the sort of presence of RV pressure overload. And we can see that there's distortion of the septum throughout the cardiac cycle, but it's most marked in mid to end systole. And this is in comparison with our image on the right here, which is volume overload, where we see basically there's sparing of the systolic septal distortion with a predominant effect in mid to late diastole. And here's a patient who had significant PEs and RV pressure overload. We can see basically septal distortion throughout the cardiac cycle. And if you're trying to make judgments in terms of volume, and in a patient with an echo like this, obviously maybe it's worth your while to expand differential, maybe take a look and the lower extremities for evidence of DVT, or look for other evidence of PE. Now, in terms of RV dysfunction, we know that RV dysfunction is common in sepsis, and we also know it's associated with increased mortality. But a significant number of patients with RV failure and sepsis are actually going to have normal RV function. So it's a little unclear how this sort of factors into your management. With that said, I do think it's worth a quick qualitative assessment in terms of eyeballing your RVEF versus something more formal like a TAPSE. It may not necessarily be indicated or that valuable. Now, finally, in terms of looking at LV function and talking about VTIs. So, I, over the years, have been reluctant, to be honest, to incorporate VTIs in my management because I found it to be pretty cumbersome. But over the years, as auto VTI tools have become more and more available, it's gotten actually a lot more streamlined, and I've sort of incorporated it a lot more routinely into my practice. Now, with that said, I typically reserve looking at VTIs for my sickest patients, my patients that have already put on pressors, definitely my patients who have a suspicion of cardiogenic shock. But even then, I'm not really calculating cardiac output. I'm just looking at raw stroke distance here, and I'm trending that along with any intervention that I may have. Now, before we wrap this up, just a quick mention in terms of lung ultrasound. And over the years, I'll say I've gradually sort of in many ways diminished my use of lung, or at least my reliance on lung ultrasound. But I do think it still has a role, and I do routinely check it when I'm doing my initial evaluation of patients in shock. So starting with an evaluation of at least 2 zones of the lung, if not a full evaluation. And then just for reference, obviously this is normal lung where we see A-line predominance versus a patient who has B-line predominance, or likely evidence of extravascular lung water. Now, credit where credit is due. The term fluid tolerance actually comes from the discussion of this paper by Daniel Lichtenstein in 2009. It's the first mention that I've seen in the literature of the concept, and definitely was what sort of prompted my sort of utilization of the concept in term when I started lecturing about this. Now, this study was back in 2009, 102 patients in the med-surg ICU, all mechanically ventilated, all who had a PA catheter. What he found was that A-line predominance predicted low pulmonary artery occlusion pressures. However, in 2014, in a multi-center trial where they attempted to validate these findings, they were unable to validate them. In fact, they found that basically these patterns of A-line predominance and B patterns were widely distributed over a broad range of pulmonary occlusion pressures, both elevated and normal. It wasn't until they basically combined it with an assessment of the LV that it sort of performance improved. So if you have an A-line pattern, A pattern predominant ultrasound along with a normal LV, that correlated better with normal pressures versus a B pattern where you had an impaired LV. Obviously, these patients more often than not had elevated pressures. Now, again, part of my problem in terms of over-reliance on lung ultrasound has to do with the fact that there are a lot of confounders, right? Pneumonia, ARDS, de-recruitment on patients in ventilators, patients that are in trauma centers, the presence of contusion. These are all can confound your evaluation in terms of causing B-lines. Where I think the real value of this is obviously looking at other confounders, right? Specifically ruling out things like pneumothorax, which can cause, evidence of venous congestion. Much like, I didn't mention it, but also the role of echo, right? Ruling out pericardial tamponade and effusion is another value there. So, there are limitations here, but it's still a part of my routine exam. The other part of this is, sometimes it's all you got, right? Like, I think about my patients in the SICU who have open abdomens. I'm obviously not getting an adequate IVC view in that patient, where I don't necessarily want to over-rely on lung ultrasound. Most people have pretty good lung windows. So it may be all that you have, and it's probably better than nothing. All right, so wrapping this all up. So we start with a patient, right? We started with a patient who has evidence of shock, and we think that this patient can benefit from fluids. So we're going to start with our basic evaluation. For me, that's going to start with looking at the IVC. The IVC has greater than 50% collapse. then I'm going to feel pretty confident in terms of giving fluid to this patient. Now, if they have less than 50% collapse, but their IVC is still relatively small, less than 2 centimeters, especially if my echo is hypodynamic, then I'm going to go ahead and do a portal vein and maybe a hepatic vein Doppler. If my portal vein shows continuous flow, then I can feel pretty confident, again, that this patient probably tolerates fluids. If my portal vein pulsatility is there, but it's less than 50%, then I'm going to follow that up and confirm with hepatic vein Doppler. If I still have maintenance of basically my relationship of S and D waves, then I'll consider giving fluids with maybe some caution. Portal vein pulsatility greater than 50%, and now I have reversal of my relationship. My systolic wave and hepatic Doppler is less than diastolic wave, then I'm going to hold fluids, and if they're in shock, I'm going to potentially start pressors, and this is where I'm going to start trending VTIs. Now, on the other hand, if I've got a respiro-static IVC that's enlarged, especially if I have evidence of RV ventricular interdependence, and if I'm finding severe evidence of venous congestion on my Doppler, then this is the patient, not only am I hold fluids, but I may even consider diuresis in these patients. Clearly, if I am going to do something like that, I'm going to be trending VTIs and see whether or not the patient improves. All right. So with that, in terms of references, if you go to the emergency department website over at Elmhurst, follow it to critical care lecture series. I've got a page built for this lecture. It has a handful of the articles that I think are worth reviewing, as well as all of my references that are available with PubMed links. And with that, we can, I guess, open this up for discussion. And if you have any questions, comments to me, feel free to email me. I'd love to hear from you.
Thank you so much, Dr. Myers. Those of you who have questions, would you raise your hand or just type them into the chat box, please? Thank you, Dr. Myers, for the latest attempt at demystifying the complex issue of the role of fluids and the estimation of fluids in the management of patients in septic shock in the ICU. I especially like how you've broken it down into green, caution, and red, because many such reviews try to be binary. And as we all know, nothing is binary. There is a huge chunk of gray between the two extremes of black and white. Now, just my pet discussion peeve with the Rivers trial was that there was much more at issue than just obviously the CVP, as you are probably aware, all the other issues, which really surprise. So it's a surprise to me that people still quote that study. That study has really been thoroughly debunked in a way, and honestly, my feeling is, I'm from a time when there was, the continuous oximetry SWAN, and what they had done was to put a pulse oximeter on the tip of a catheter, and then when SWANs went out, they figured, let's put oximeter on the tip of a catheter and call it whatever it was called, CAT-SEP, SEP-CAT, or whatever that was. And that was probably one of the genesis, of having such a complex protocol and algorithm for this protocol-driven connection. Any comments?
I'll say that, like, I do agree. I sort of added that sort of comment about early goal-directed therapy to be provocative in a sense. Obviously the early goal-directed therapy sort of loomed large during my training in residency and fellowship. So I always sort of come back to it in terms of referencing, and I think it changed a lot of people's approach. And one of, I think, the downsides to it was obviously sort of the misunderstanding of the right atrium and right atrial pressures. And I think it definitely illustrates exactly how far along the sort of critical care community had come in terms of the ideas of hemodynamic optimization, that both the control and experimental arm were targeting supraphysiologic CVPs, right? That's sort of the only reason why I brought that up. It sort of amazes me that that was considered okay when they designed that study. That wasn't a common feature of the rest of the studies of the Promise trial, Process trial, Arise trial. They did not include that in their standard care control group. So it wasn't reevaluated, but I think it is one of those components of the design that I know I wasn't actually aware of until much later, that I always thought the CVP component of therapy was one of the novel components, and it wasn't. So that's sort of the reason why I ended there, but I intended it to be a little provocative.
Yes, thank you. Actually, by your definition of interesting parameters, one was the oxygen delivery, and then the need to transfuse if it didn't meet a certain criterion or whatever, which was antithetical to everything we had done till then and do since, as you know. I'm asking folks to ask questions, and if there aren't any, then I thank you really for a fantastic review and really attempt at rationalizing what the evidence we have so far and putting it together so nicely in these buckets.
Hey, Dr. Goodwani, this is Brian, one of the critical care fellows. I saw a question that was posted by Dr. Marc-Andre in the chat that said, how much TR does a patient need to have to invalidate portal vein pulsatility?
Well, Mark, I don't actually know the answer to that, because I don't think any of these studies actually looked or quantified TR in that regard. I will tell you though, the question is, even if you have TR for other reasons, it doesn't necessarily change the sort of endpoint, right? If you see in venous congestion downstream from the right heart, does it really matter whether or not it's from TR or from volume overload? I mean, both are basically components of the same thing. So I think the argument would be it doesn't invalidate it, because you're still left with the same predicament, right? You've got downstream venous congestion. I don't know if that answers the question. Let's see if there's anything else.
Thanks, Dr. Mars. This is Brian. I don't see any other questions in the Q&A right now.
Thank you so much. We're going to have you back again, Chad, in a year or two to update this as you have been doing every year since 2008.
All right. Hopefully we'll actually have some new data.
Yeah.
Something there.
Agreed. Thank you.
All right. Thank you.